left-sided pathways. I think by a wonderful lecture and discussion, we know how to enter the left side now. So the primary importance is before you enter left side, make sure your diagnosis of left-sided arrhythmia is made with confirmation. I've seen people take with AV nodal re-entry with left-sided inputs, and there are some patients whom your catheter is not properly inside. There are times your decapolar catheter is not properly inside, and maybe only your tip of the catheter may be inside, or it's moving here and there with cardiac movements. Sometimes when you look at ventricular activation, then it may look like a eccentric activation. So before going to left side, make sure you need a left-sided access. You can look at your decapolar catheter. If by chance you have any doubt, you always do maneuvers to make sure that what you are dealing and what you are trying to do is a left-sided arrhythmia. Regarding access, you can have multiple ways to do a left-sided entry and access. With a regular access, sometimes people use pigtail for a transeptal access. In that case, you need an arterial access. There are people who do with his catheter, in that what we call as a veno-venous access, where you can put up his catheter for identifying a NCC. In my practice, most of the time, I use pigtail because we are all trained to do transeptal from our BMV days. So I always use pigtail. But one more thing I do is I always try to get a his also across. There are times, particularly in a not so typical atrial routes, you may not be very sure that you are in NCC. Sometimes you may have been thinking that you are in NCC, but you may not have gone to the NCC, and you may have kept your catheter in maybe an RCC or LCC. So in that time, it will completely misguide you in taking a transeptal access. What I do is, after putting a pigtail or before putting a pigtail, I have a his catheter. So make sure that pigtail is in the NCC. Sometimes a lot of people during BMV days, they used to do a small puff of contrast in the aorta and check are we in the NCC, or this also helps. Do you want to go left side by a transeptal route or retrograde route? It's your preference, but I prefer most of the time a transeptal access. Most of my arrhythmias from left side, including pathways, are ablated by a transeptal route. The reason being, it's simpler. You get a better contact, and your maneuverability is much better when you go a transeptal route. In retrograde route, you limited by the rotational capability of your catheters. Second, because you're very much deep inside and you're hinging on the valve at the annulus level, sometimes delivery of energy also may not be optimal when you go a retrograde route. Getting a good A, which you love to have in most of the cases with pathway ablations, may not be possible when you go a retrograde, because getting into the atrial side of the annulus is a little difficult when you go into a retrograde route rather than an antegrade route. And secondly, when you have a particularly a posteroseptal, which is very close to septum, when you have pathways, or when your arrhythmias are coming very close to the septum, sometimes it may be difficult to enter through a retrograde route, because you may not be able to straighten the catheter that much. One area where your retrograde may have a little more comfort than a transeptal route may be a true anterior pathways, where you have an anterolateral or anterior pathways, where you may not be able to go with a deflection into anterior space. Your retrograde route may be useful, but you have catheters like sheaths which can face you anteriorly. I think most of us take transeptals with either SL1 or SLO. Both of these sheaths are going to make you to face anteriorly, thereby making your life easier even with the anterior pathways. Most of the electrophysiologists, we don't take transeptal punctures with Mullins. So you have a SL1 or SLO on your hand, so that makes your anterior access also possible. So I use transeptal as a primary thing for getting into left side. You want a 2D or you want a 3D mapping system for a regular arrhythmias. I think for a complex arrhythmias, we all know we love to have a three-dimensional mapping ready. But for us, I think in our setup at Covai Medical Center, all our arrhythmias are ablated under three-dimensional mapping. So most of our left lateral pathways are also ablated by a three-dimensional mapping. I think we felt it very comfortable for two reasons. One is fluoroscopy. Definitely, your fluoroscopy is hardly there. After you have a transeptal access, you hardly require a fluoroscopy to get into the pathway zone and deliver. That's very important, in particular in a high volume centers, to look about fluoroscopic time. And second, the consolidation of lesions. There are times, it's not very common, though, there are times you have a really difficult pathways. Sometimes they are not truly endocardial. You may not be able to get out of the pathway by giving a lesion from your non-irrigated catheter. There you may have to further consolidate the lesion with the irrigated catheters. In that time, having a 3D is very helpful, because pathway may have partially gone or would have gone and intermittently coming back. You may not be able to map clearly, but in a 3D map, you have the location where your pathway was, and you can go there and ablate. So consolidation is pretty good. I should say we are using 3D mapping for the last maybe 5 years for all our SVTs also. I started to see lesser recurrences when we have used a three-dimensional mapping for pathways. Energy source, I think most of us use radio frequency energy as a primary source for ablating left-sided arrhythmias. I think if you have a difficult arrhythmias, or when you go close to conduction system, which is very uncommon on the left side, we may use the cryo energy. I think you don't ideally need a cryo energy for a pathway ablation when you are doing a transeptal access and going across and delivering. Maybe cryo energy is useful when you are doing a PBI. Irrigation, as I already told you, that you need to have a irrigation once in a while. I think maybe I should say less than 2% of my left-sided ablations have required irrigation. The consolidations, particularly recurrent pathways, the populations which have been ablated elsewhere, they come with recurrence. You go in and ablate, you really understand that it's not that easy. It's not truly endocardial. So you may have to use a irrigation in these kind of situations to completely take care of the pathways. Endpoints are very important. This is very important, particularly when you have a manifest pre-exudation. A lot of times we tend to see a pathway going off, and we are happy with that, give an adenosine check and all that, all is fine. But looking at a ventricular VA activation is also very important. There are times your pathways are not really straight. They can be oblique. I have seen few of the pathways where your antegrade and retrograde directions are in a different places. It's a completely oblique pathway, while you've completely taken care of a pathway in a pre-excited situation. You would see that still your pathway is conducting by a retrograde route. So your AVRT needs only a retrograde conduction. So your AVRT will still be inducible. So make sure that you look at the VA conduction, you look at induction, not only at the baseline, at the isoprolene, and you wait enough. And most of the antegrade pathways, we give adenosine at 12 mg to check if there is any activation happening at the pathway after you block a AV node. So we know axillary pathways, it can be either a manifest pre-excitation or a concealed pathway, which can only conduct retrogradely. So when you can have either orthodromic or antidromic tachycardia coming out from this. ECG, if you have a clearly a WW pattern, you know you are dealing with the pathway-mediated tachycardia. Pathways are named according to the position. As I told you, you won't see a pathways close to conduction system in the left side, because conduction system is oriented towards right side. So your left-sided pathways are primarily could be a posterior, could be a posterior, posterolateral, lateral, anterolateral, or anterior. These are the usual locations where you get a left-sided pathways. The most common location where we are going to see a accessory pathways lateral or posterolateral. Either a 3 o'clock or a 3 to 5 o'clock position is where you are going to see most of your left-sided pathways. And anterolateral anterior pathways are rare. Anterior pathways are not very common. You rarely see them. As I told you, when you see an anterior pathway, you may require, particularly if you use a transeptal access for Mullins to take a transeptal access, sometimes you may have to take a sheath which faces anteriorly, like a SL1 or SLO, to go through anterior side. Most of the other pathways can be easily ablated by any sheaths what you use. And Post-receptor pathways, you have to be very careful because sometimes it's difficult to identify uh, where from the trigone area your pathway is located. So this is a zone where you have a lot of epicardial pathways also. Sometimes these epicardial pathways, particularly CS diverticulum, because they are located more closer to the left side, they may look left-sided. So when you have a post-receptal pathways, it's better you have a anatomical orientation of the CS also. I usually, whenever I have post-receptal pathway and I see some unusual signals or it's not exactly at the location where you usually expect them to be, I usually do a coronary sinus angiogram. You can just take a AL and get into the coronary sinus and give an injection and see to make sure you are not missing diverticulum. I have seen few of the cases done outside as a left-sided pathways. They recur. When you come back and see, you would see a diverticulum and a mouth of the diverticulum. There will be a pathway because it was looking maybe post-septal kind of a location. People would have gone left-sided and ablated, but ultimately it was a right-sided pathway with the diverticular connection in the CS. So always make sure that you have your diagnosis clear. So I'll share two cases, one typical concealed pathway and another manifest pathway. The baseline ECG, as expected, you don't see any pre-excitation. And baseline intervals, HV interval is normal, telling you that there is no pre-excitation. But when we are going to pace from the RV apex and look at the ventricular activation, you can clearly see this is the way my lab CS is positioned. You could see like CS12 is the top one. That's a distal mode CS. And CS910 is a proximal CS. And the first catheter after ECG, what you see is a His catheter. So His catheter is recording a His. You could see in the initial 3 beats, the activation is concentric. That is, your PCS, which is 910, is recording the earliest A, followed by 7, 8, 5, 6, 3, 4, and the distal most CS is recording the last to be activated atrium. And you can see in the His catheter, your atrial signal in the His is the earliest. It's preceding all the coronary sinus activation. It shows it's a concentric activation. Your VA is going through the node. You look at the fourth one on the picture, the fourth QRS complex on the picture, you could clearly see there is a change in the activation. Now, your distal 1, 2, that is the distal most pole inside the coronary sinus, has a earliest A, while your proximal CS has become late. Not only with that, you could see that the His atrial activation has become later now. I'm not able to use my arrow. Okay. So his activation has become later now. So this this picture, you can clearly see the activation has become node to a pathway at the fourth beat of the picture. The first 3 beats are going through the node and fourth one has started getting into the pathway. So clearly you can see here there is a small change. You could see that now the CS12 is in the bottom. This is very important because every lab uses the different protocols. In this lab, you could see that the 1-2 is in the bottom and 910 is the topmost, or proximal CS is the topmost electrode being depicted, the third one. So here again, you can see the distalmost CS is recording the earliest signal, while His is activated later, suggesting you have a left-sided pathway which is conducting, which may be the reason why you have a left-sided arrhythmia. So now we have induced arrhythmia here. Again, here you can see that the activation of CS12, which is deep inside the left side CS deep proximal pole, is recording the earliest activation, while your CS proximal poles, which are inside, maybe close to the right side, are not recording the early signals, and your His is also delayed. So this clearly shows the arrhythmia is happening at the left side with left-sided activation preceding the right side. So we can do a ventricular entrainment to see what is the response. Usually you should get a VAV response with a PPA TCL should be less than 110. Because left side, sometimes your PPA-TCL is in the range of hundreds, because in right-sided pathways, we usually tend to see a lesser because we are very close to circuit. Here, because on the left side, you are facing from RV apex and checking. Sometimes your PPA-TCL may be closer to 100. So this is saying that you are dealing with a pathway. This is again important to make sure you are dealing with the pathway. Sometimes you may not have clearly seen a VA eccentricity during a ventricular pacing, and you see a arrhythmia which has a earliest activation in the distal CS. This could be a atrial arrhythmia coming from the left atrium. So you have to make sure that you are dealing with the pathway before you go on to ablate this arrhythmia. If you have done a VA eccentricity, you know there is a pathway. Sometimes you are not able to do, or there are times you will have an incessant arrhythmia which will never allow you to do a VA pacing. Also, there you have to make sure that you are dealing with the pathway by looking into the ventricular entrainment. So most of the time, we prefer to ablating these pathways during ventricular pacing. The reason being, catheter stability is much better when you pace ventricle rather than you go on during an arrhythmia. When during an AVRT, your catheter is jumping around. So if by chance, particularly when you do a fluoroscopic ablations, sometimes you are in the place, you ablated the arrhythmia, the ablation has terminated the arrhythmia, the catheter was jumped out. Then again, going back to the same location may be difficult. There are times what we do is we put a ventricular catheter, you go ablate during an arrhythmia, and we start pacing immediately the ventricle when the arrhythmia terminates. The small few seconds gap also can make your catheter jump out from the location. And if you are in a two-dimensional mapping, sometimes this can be difficult. Pacing ventricle and ablating is easier. You have to go and pace the right ventricle and find out which is the earliest activated coronary sinus catheter pole. Here you could see that CS12 is the activated earliest, and you can clearly see your ablation catheter, which is in the lower part, is showing a earliest atrial signal, which is preceding the atrial signal which is coming in the CS12. You have your ablation signal just below the CS12. And when you are looking at the signal, the 1-2 signal is clearly beaten by the ablation distal atrial activation, clearly saying you are in the earliest part of uh, ventricular activation, and the pathway will go off when you ablate here. So when you started ablating, the VA got terminated, VA got separated, and you started having a VA block. It clearly shows that you have been ablating in a proper place and you have taken care of the pathway. And now your VA conduction has become nearly, you hardly have a VA conduction because atrial conduction has completely stopped. And you don't ablate long. I think when you are ablating in a proper place, within 10 seconds, you should get a VA separation. If you don't get a VA separation in a particular place, don't go on delivering more than 15-20 seconds, because you may partially damage the pathway, and pathway may come up at a later date. Rather than delivering at a place where the pathway is not there, you map further to identify the separate particular place from where the pathway is coming and deliver. Most of the time, your pathway should go off within 2 to 3 seconds. So I don't usually give energy more than 10 seconds before changing it to a place. So there's no arrhythmia is inducible in this particular patient. So next one is a manifest pathway, where you are going to see a manifest pre-excitation. You could see a clear manifest pathway with V1 showing positivity and short PR. So I'm going to on again. So this is how it looked like when you are started ablating. So you could see that ablation signal. The signal in the ablation is pretty good, and you're able to terminate the pathway conduction. The adenosine, there is a AV block. You can see there is only a signal is seen in the third beat. There's no conduction through the pathway or AV node. AV node we already blocked with adenosine. So because there is no pathway to go along, so there is no VA conduction at all. You have to always check the pathway conduction whenever you are delivering. This is another case where we have done recently, I think 2 days back. You could see a manifest pre-excitation in this particular patients, around 20-year-old female, recurrent palpitations with a WW syndrome on the ECG. And V1 is not fully pre-excited, so you could see that PR interval looks okay. other leads, particularly a lateral leads, you could see a shorter PR interval. Sometimes you have to be very careful in looking at these ECGs. Sometimes it may be a minimal pre-excitation, particularly in a left-sided pathways. When you pace this atrium, you will see a better pre-excitation. So when we go in and started mapping, you could see the HV is very short. You can see the his catheter, which is colored in yellow, and you can see a spiky potential, which is a his potential, and his is hardly around 20 plus is the HV interval, saying that you are dealing with a pathway. So we know a pathway, and you can see a CS activation also. There is a nearly a few signals which you see in a CS1-2, which can be a suggestive of a left-sided pathway. When we did a ventricular activation, you could see the activation is eccentric with distal electrodes in coronary sinus recording the earliest EA, and the proximal is recording a later activation, showing you that there is a pathway. So AVRT, there's an orthodromic AVRT which got induced. You can clearly see that the earliest activation again in the distal CS and proximal CS is late. And not only that, when you look at the His signals, you can see your His activation. The His CA is very late, telling you that you are dealing with the left-sided pathway. So whenever when you map a pathway, the one thing we should always look at is what we call as a accessory pathway potentials or a Kent signal. You have to map in the sinus. So it's usually a low amplitude but high frequency signal. It usually consists of atrial and ventricular electrogram. You usually see during a sinus rhythm, but you can see during a atrial or ventricular pacing also, or during a tachycardia also. In this particular patient, you can clearly see that. You see, particularly if you see 1, 2, 3, 4, fourth beat, you can clearly see a spiky third and fourth beat. There's a spiky potential which is in the middle of your atrial and ventricular signal, which is highly suggestive of an accessory pathway potential. So when you see this potential with a fused AV, you know you are bang on the pathway, and delivering here will take care of pathway in a big way. And this patient, I think, lost pathway conduction in around 2.6 to 3 seconds. So you can see here the last 2 beats in the tracing. The first around 6 tracing beats have a A and V which are fused. In the last 2 beats, your A and V got separated, saying that your pathway conduction is gone. You can look at the CS activation also. The CS 1, 2, 3, 4, which are fused, now have a separate A and V. And if you look at your surface G, there's a complete change in the morphology of V1 and AVL. So you have lost the pathway conduction here. So this pathway has been ablated in 3 seconds. So post ablation, we checked VA from LV. We paced the LV catheter. There was no VA conduction at all, even at 550 milliseconds. And another thing what we did was we gave adenosine 12 mg and looked at the AV block. There's a complete AV block. When the AV block is happening, there is no conduction coming from the pathway, saying that there is no antegrade or retrograde conduction. So at after ablation, even with isoprolol, there was no induction of a tachycardia. You should always do this because there are times we have seen a patient with the left lateral pathway can also have a AV nodal reentry. So you have to induce aggressively post RFA to make sure that you are not missing any other arrhythmia or this arrhythmia recurs. So with this, we can be sure that we have ablated the arrhythmia. So post RFA, there's no evidence of pre-excitation now. You can see V1 morphology and AVL and 1 have completely changed compared to the previous baseline ECG. So this patient has lost the pathway conduction. So this done through the transeptal route under 3D mapping. So this is the baseline ECG and post RFA. You can clearly see patient has lost the pre-excitation. We did under 3D. So 3D map, you can clearly see that we gave around 3 lesions, maybe around 60 to 70-second lesions, maybe 180 seconds of consolidation. That's what we did in this particular patient. I usually, what you do when I have a 3D map with me, I go in, ablate, once you take care of the pathway. Maybe sometimes your pathway goes off in a larger V with a smaller A. In that situation, I pull the catheter and deliver 1 or 2 ablations with a larger A. so that you deliver on both sides, atrial and ventricular side of the pathway. So with this, I'll close the talk.